There are 3 important steps prior deciding on the next surveillance interval. Step 1. Clinical history. Firstly, determine a patient's risk of colorectal cancer, either average risk or high risk. Second, it is important to consider the endoscopic and histological features, including resection margin, to further stratify the patient's risk. Third, is comorbidities. Clinicians should weigh the risks versus benefits of further colonoscopy surveillance for the patient. Step 2. High-quality colonoscopy. Clinicians must ensure that the index colonoscopy is done with good bowel preparation, Boston scale of 6 and above, cecal intubation, as well as complete polypectomy. Third and last step is to glance through the pathology result by checking for features of advanced adenoma and serrated pathology. Once we have the clinical information necessary, we can now move on to select the most appropriate surveillance interval for our patients. Recommendations for first PPS. A 3-year interval is suggested for patients after polypectomy for advanced adenoma and advanced sessile serrated polyp. For piecemeal resection of adenoma or sessile serrated polyp of size 20 mm or larger, first surveillance is at 6 months. Second surveillance is 1 year from first surveillance, while the third surveillance is scheduled at 3 years from the second surveillance. On the other hand, patients with low-risk adenoma or normal colonoscopy findings, a 10-year gap is safe before the next colonoscopy. Patients with more than 10 adenomas detected during this index colonoscopy should have surveillance done at 1 year and also suggested for genetic testing. While for patients with more than 20 hyperplastic polyps distributed throughout the colon should be investigated for serrated polyposis syndrome, which carries increased risk for colorectal cancer. Recommendations for second PPS. Clinicians should take into account the findings at baseline and most recent surveillance colonoscopy. Similarly, a 3-year interval is suggested for those with advanced adenoma regardless of baseline findings. The slight difference is that in patients with normal or low-risk adenoma in the latest scope, but had history of advanced adenoma at baseline, surveillance should be done at 5 years. All these recommendations are only applicable assuming complete examination till cecum with adequate bowel preparation to detect lesions more than 5 mm among individuals with average risk. Therefore, patients with suboptimal colonoscopy will have the next surveillance interval decided based on clinicians' discretion.